Just wanted to touch on some functional strength training for the older adults. And in making this, I always feel like there's so many different avenues that we can go, but try to kind of keep it focused on the functional side of things, but also kind of how we get to that point. So there will be a case included as we go. And our objectives are to look at some of those signs and symptoms. So for those healthcare individuals who are doing more of the screening to identify when it's beneficial for referrals to either physical therapy or occupational therapy for that strength training. Also explain some of the benefits of strength training for older adults and how to reinforce behavior change. That's always, I think, one of the hardest parts for anybody, not just the older adult, but how to get anybody to work on that strength aspect. Because I always feel like, as we'll discuss here, the sooner we can get on the strength training program, the better for the older adults. So this is our case presentation. I'll read through it briefly here. We have Robert Thompson. He's 72 years old, and he is a retired school teacher who was referred to physical therapy by his primary care provider for participation in a strength program due to gradually worsening weakness and decreased functional mobility. He is reporting that over the past 3 to 5 years, he has noticed increased difficulty rising from low chairs, fatigue when walking longer than 10 minutes, and he's avoiding stairs because his legs feel weak. He states he'd like to begin exercising, but he's not sure on how to do that safely. And he's concerned about injuring himself if he starts lifting weights. His past medical history includes controlled hypertension, type 2 diabetes, mellitus, and mild bilateral knee osteoarthritis. He lives with his spouse in a single level home, and he's independent with his ADLs and drives independently. So fairly high functioning, but you can see there's still some impairments there. The questions we're going to be discussing as we go through this case, and we'll do these one at a time. I just want you to kind of get them in the forefront to kind of be thinking about them as we discuss a few things here. So is his presentation normal for his age? And then what signs and symptoms would have maybe triggered the referral that he did get for PT? Why is strength training beneficial for him? And we'll do a little bonus on kind of what's the best way for him to do his strength training. We'll discuss some of his barriers and how to facilitate that behavior change. So to begin with, we'll talk about there are actual age-related musculoskeletal changes that do occur in the body. And the changes that happen that decrease these areas are in the muscle fibers. So especially the type 2 muscle fibers, which are the fast twitch. They help us do quick motions. You think of these with power motions. So if we have to quickly get up and go answer the phone, or if we have to quickly cross a road to be sure that we get across before the light switches. So it's kind of turning on those quick acting muscle. Those actually decrease the most in the older adults. And a combination of factors we'll talk about a little bit later too. There's also a decrease in the muscle mass where we'll discuss sarcopenia. And this is partly age related. There are other components as well. There's also a change in the elasticity of tissues. They don't have that elastic component. It starts to break down. And so tissues can become stretched out or more stiff with motion and can contribute to injuries, which we'll discuss. There is actual vertebral disc height changes And so you may, if you go to the doctor and have your height checked each year, in your later years, you might start to notice that go down slightly. Some of that is due to the actual disc height change, but also can be due to some of the postural changes that occur. And that postural alignment is also a component that can be decreased. And then the bone mineral density, because of the increased osteoclastic activity, there is generally more breakdown of that bone. Now, the things that are increased is you can see an increase in muscle fat and connective tissue, which there again impacts that ability of the muscle to be the most efficient. And why do these things happen? There's a variety of components that lead to these changes. An actual apoptosis, where there's programmed cellular death, which can lead to that atrophy of the muscle. The oxidative stress and inflammation, I know it's a big one that we hear about with diet and knowing how exercise can minimize that. But if there is excessive inflammation, we have an increase in the free radicals there. There's the actual neural changes that affect the muscles, so decreased motor units, conduction, and excitability. So being able to pass that neural signal down the line to the muscles is slower and can affect how well the muscle is able to contract. Tendon changes. So I mentioned the decreased elasticity. So those changes in the tendon can make it more likely for injury to occur because they don't have that elasticity to bounce back, and less ability to repair. The osseous structures decline, which I mentioned already, and the osteoporosis can be a significant factor to monitor as well with that breakdown of the bone. And changes in the ability for that calcium, vitamin D, even the absorption of that, and kind of the mobility factor of getting out, getting that natural vitamin D also affects that bony, the osseous structure. The OA, that should be kind of brought to the left-hand side there, but for this patient, he has osteoarthritis, which can be a major cause of pain and dysfunction, which can lead to that kind of negative cycle of immobility. But I think most people may have seen this already, but just a chart to depict the effects of age on maximal strength. So you see throughout the years here, we kind of hit the peak of our muscle strength in our 20s and 30s. And then from there, it starts to decline. Generally, they say about 3 to 8% per decade of muscle mass loss throughout each of the decades. So, and you can see here the concentric, the muscle shortening. If we're talking about like biceps, when we pull up, that one is more affected. They'll lose that ability much more quickly than eccentric, which is that lengthening of the muscle as they maintain activation there. And so that can affect different functional activities. And where this becomes important is, in early life, if there's not a lot of variability between people, and we sit much higher on this ability scale with our muscle mass and strength, which translates to our higher levels of function. And then as we go through the adult years and older years, you can see that this range amongst the population becomes much larger. And those who maintain that strength and stay, even though they have a loss of strength throughout the years, if they're able to combat that with some strength training, they're going to stay at that higher end of the range. versus those who aren't doing anything to work against that loss, they're going to end up on these lower ranges. And what then happens is they become more susceptible to disability if they have even one slight setback. It's going to be much harder for them to come back from that versus somebody who stays at this higher end. Even if they have a setback, they have a lot more reserve to essentially bounce back. So that's the overall goal that we really all want to maintain in life, is to stay at that higher end of the range. Even though, it can be hard to think, that we're all going to lose muscle mass, but it's just how much of that, and we have control over that. So an important factor to remember. So with Robert's presentation, is what he's presenting with to the doctor, is this normal for his age? Based on what we talked about, it's normal to have a decrease in muscle mass, but is what he presents with, is this normal? So go ahead and look back through here and kind of put things together. What do you think you would say? Is this normal for him at age 72 and kind of how he's presenting? And if you want to write in the chat, you can say, yes, this looks like a normal age-related muscle mass decrease, or no, or I don't have enough information. Yeah, so I see some people saying seems a little early in life for this much loss. And right now we're just going based on his function, right? We don't have a lot of measurements. Yeah. So it seems like people are kind of saying either doesn't look quite normal for this age or not really sure. Maybe there's not enough information. So let's keep going. Yeah. Okay. So with I mentioned the changes to the type 2 muscle fibers, so those power changes. That is the ability to generate that force rapidly. It is a very strong predictor of functional status in the older adult. And it does decline at more than twice the rate that, if we think about just like a slower speed strength activity does. And so when you think of power, you think of jumps, punches, kicks, tackles, throws. I mean, that kind of makes you think of young kids, like maybe toddlers who are like bouncing off the walls. And then just naturally, as we get older, we do just less and less of this, right? And so there's a component of not using it, but also that age-related change of the changes that occur with the type 2 muscle fibers. So when we talk about kind of training this, it's recommended that at least 2 times a week that older adults participate in the resistance training. And that can have an impact on how much muscle mass they're able to maintain. Now, the other thing to consider is heart failure can decrease how much power the older adult can generate, just based on the function of the cardiovascular system and how that contributes to the muscle activation. But where this becomes important is in the concept of sarcopenia. And so here in this picture, you can see that muscle mass loss on the right-hand side. And the definition of this is an age-related syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. And it comes along with an increased risk of adverse outcomes. And so if we look at that trajectory over time, if they have that reduced muscle mass, they're going to sit on that lower end of the range and have less ability to come back from any changes. that might occur in their life, either medically or environmentally. But it's formally a greater than 2 standard deviations below the healthy young adult mean. And so this is kind of where we would need more information from our patient to actually do some more measurements to see where they at along these norms, and are they getting to that sarcopenia kind of stage or concern. And it's not just because of disuse. There are other factors that go into sarcopenia. So some of these causes, physical activity is at the top of the list, number one. But there's other components as well, such as loss of alpha motor neuron input. So that's that neuromuscular aspect with the age-related changes that we were talking about. Also, there can be a decline in testosterone, which can impact that muscle mass and building ability, changes or declines in the growth hormone. And then lastly, the protein deficiency. And I think we've had past webinars on the importance of nutrition and that protein intake. So that could go, like any of these topics, you could take a whole nother session and discuss, but important to kind of know it's not a one factor cause. But if we can identify if there's a risk for sarcopenia and then break it down to see where could we make the most change. And so then it's thinking about what can we modify with this. We might not be able to modify the actual neuromuscular changes, but we can increase the strength to make that more effective. And then as far as testosterone and growth hormone, that would remain in the medical side of things to see if there's any medical management that would be needed there. And then reaching out to our nutritionist or dietitian to manage that protein deficiency if there is one. And so some of you might be familiar with the SARC-F. I think, can you still see that on your screen? Or did I stop sharing? Let's see.
We can see it.
Okay. And so this would be a screening tool to look at strength, assistance with walking, rising from a chair, climbing stairs, and falls, and giving a rating for each of those. So since we're on this, we could kind of go back to Robert and say, it didn't say anything about difficulty carrying or lifting. So we might want to ask about that, though. We could ask about how much difficulty he has walking across the room. From the information we have, it doesn't seem like he has any trouble with that. But rising from a chair, he was saying that it was getting more difficult. So you might rate him like a 1, so some difficulty there. With stairs, he was actually starting to avoid them. So I would rate him in that a lot or unable. He might be able to do some, or he just has a lot of difficulty there. And then we'd for sure want to ask about the number of falls. And so the falls, if there was no falls, it'd be a 0. 1 to 3 falls would be a 1. And then 4 or more falls would be a 2. So you add up his score, he's probably with the stairs and the difficulty rising from a chair, he might get a score of 3. And then if you get a 4 or more, that's predictive of that sarcopenia and that that difficulty with climbing stairs and that rising ability. So he's kind of starting to he maybe is not quite at that sarcopenia stage for diagnosis, but he's starting to show signs of that. The SARC-F tool, if when you get the slides, you can click on this link or I can include the link in the chat as well at the end. But just kind of to emphasize, there are things you can do to prevent progressive sarcopenia. If we look at this top slide, this is a 40-year-old triathlete, a young patient, right? So we expect good muscle mass. Then we look at a 74-year-old sedentary. Look at all of that muscle loss and then the fat around that and just how inadequate that muscle mass looks. But if we look at a 70-year-old triathlete who was, very active, they can maintain a lot of that muscle strength. There's changes here, but it's very different compared to the sedentary. So that's what gives the older adult hope that they can do something about this. So what signs and symptoms for Robert do you think triggered the referral? I'll go here. Is there anything in particular? We mentioned the function because we didn't have a lot of formal assessments or measurements. But what in his function, based on what I talked about with the SARC-F, kind of jumps out at you? You can put it in the chat. Yep, the trouble getting out of the chair, fatigue with walking. And with that, he is likely going to be a fall risk too. And that would be something we'd want to assess, especially when he has such difficulty with the sit to stand. Yep, and the stairs, exactly. So I think you guys, they're fairly obvious right there. But yes, I think anytime we start to notice, either the individual notices or somebody else notices that. I mean, even in the clinic, you can see how they just get up from the waiting room chair, or if you're in the home, you can see how they move around their home. And this can be, a good starting point to say, what are you doing for this? Here's the things that you can do to prevent that loss later in life and keep you functioning at the top of your game. So just to emphasize the ACSM FIT guidelines for the older adult, these are specific to the older adult, and you can see they include aerobic, resistance, flexibility, and balance. So this is especially highlighted with the older adult. But I just want to come down here. The main thing is, yes, we can start with a light amount of intensity here, but we do want to remember to progress that intensity so we get up to a higher load and workload to challenge those muscles as well. So I always tell my patients the last 2 reps should be challenging. And if we're getting to 15 reps and it's still easy, it means we need to make it a little more challenging for that person. And so here you can see those sets and reps, but then remember those type 2 muscle fibers are the most likely to decline with age. So we really do need to train power. And I think it's one of the biggest areas that we lack. But a lot of this can be kind of scary because maybe they don't do it or they're not sure if they're going to be safe. So setting up that environment so it is safe for them to practice those quick movements is important for their ability to manage those quick reactive balance steps and those higher functioning activities they need to be able to do. So they do recommend even what's called a cluster set. So if you think of this as less than 4 repetitions, but the key here, it's not a nice, easy 4 repetitions. It's like, okay, maybe we have you hold on to the desk and we're going to go up and down, sit to stand as quickly as you can 4 times in a row. And again, that needs to be sometimes a little bit lower on the intensity in order to get that speed. But then it also needs to be enough challenge to be able to build that muscle strength. So that's where a lot of that training and education is really helpful, and individualized setup for that activity. So it will work for that person and they have the self-confidence to be able to do that. One thing I want to point out is 1 rep max assessment. So this is a chart. There's when we're in the clinic working with a patient, we can use estimates of this. We're not going to get an exact measurement of a 1 rep max. We don't want our older adults doing the activity at the highest intensity where they can only do 1 repetition, because they're working at the top of their their ability, and this could put them at risk for injury, right? If I gave somebody a huge barbell, at what I think was their 1 rep max, meaning they could only be able to lift it 1 time and that's all, that's going to be a really heavy weight. And so we don't want to start there. But we would start down in the 10 to 15 rep range. And then this would kind of get us to that 65 to 75% of the 1 rep max. So that's why I always say, if we're getting up to 15 and it's still pretty easy, we're starting to get into those lower intensity ranges. So then we need to consider increasing that load and increasing it at the right amount for that person, a little at a time. And some of that is a little bit slower with the older adult, because we do have to build that trust and also do the post assessment to see how they do with that later into the next day or two. But also being sure they understand that if we are working on muscle strength, there is going to be some muscle soreness, some post-exercise soreness. So having that conversation so they know what the expectations are really important. Now, the other thing I want to go back to is consider a sit to stand where somebody has to use their hands to help them stand. That technically would put them at their 1 rep max, or even below that, because they're having to use their arms to help them and they don't have enough strength in their legs. Now, there are other components. With our case, he has osteoarthritis, so pain can be a limiting factor with that as well. But just kind of think, if we can build that reserve or that capacity of muscle strength so they can do that at those higher reps, they're going to be sitting much higher in that range and less likely for disability if anything comes down the line. So strengthening, I mentioned always kind of starting low with that 40 to 50% of the 1 rep max. But we can't stay there. I think sometimes people get comfortable there and they decide, this is what I'm going to do, and they don't progress that. But that's a big key factor for strengthening, is that we do need to gradually progress that up. Individualized progression. So considering those MSK conditions. So in this patient who has osteoarthritis in the knees, that sit to stand might start off to be a little uncomfortable, but I always provide education to say, we're going to modify this. So maybe we start at a higher height, so it's not as straining on the joints, because we need to build the muscle strength to support the joints. And as you get stronger, you're going to be able to tolerate more. And then we can gradually bring that height down to be able to tolerate that. And there's going to be a wide variety of abilities. So we do need to kind of see where they're starting at and go from there. The overload principle is just the idea we have to add progressions. And they do recommend that these are the minimums. If we go back to that chart, that's the minimum. But we should be encouraging our older adults to exceed that, because there is potential for more. It is more and more important with increasing in age. So even if yourself, if you are not strength training, you should be. And so you can take this for your own personal use. I myself need work on this every day to keep doing my strength training. I mentioned the cluster sets already. We want to get different muscle contractions. So isometric, static holds, concentric, where we're shortening the muscle, eccentric, where we're lengthening. So if you think about sit to stand, we can get that when we come up, we get primarily that concentric. When we go down, we get primarily that eccentric. So usually if you're moving through a range, you get that variety. And then it is recommended to have supervision with machines and free weights because you want to be sure that they are being used appropriately and safely. And then the multi-component factor, not everybody considers this, but if you can include at least 2 or more components, so if we think about muscle strengthening and power, or power and endurance, we can reduce falls risk by 32 to 40%. So somebody mentioned that how muscle strength can impact that fall risk. But if we can include at least 2 components within an exercise program, it can reduce that. And warm-ups and cool down for cardiovascular disease. And they also emphasize the importance of that behavioral strategies. Any of us, to make a behavior change, we have to be supported. So whether that be social support or self-efficacy support, that confidence to be able to do that is a lot of what we can do in those individualized sessions, giving that feedback, positive reinforcement, and then monitoring those vitals throughout. But I think this is also really important to educate your patient on so that they can know what the right amount of intensity is, so that rate of perceived exertion. So why would strength training be beneficial for Robert? And a bonus, what would be the best way for him to do the strength training? So take a minute, you can write in the chat if you want. If you have some ideas for a strength training activity, you could add that in. It's important for him to reduce falls. Yep, be able to complete more activities. Some ideas, sit to stands. Yes, I love that. Progressive walking, new step with low resistance to start. And it's important for him to be able to get up down from chairs, the toilet, all those functional activities that will help improve his independence and ADLs down the line. Yep, he's using his arms right now to help him get up, but maybe he can progress to without. Yeah, low impact group training. So that group aspect can be very helpful for the social reinforcement and support. If you have friends going, they're going to expect you there. So it's going to be easier to get to that. And then adding in some balance activities. Yep. So going back, one thing that I find people sometimes get stuck on is, oh, I'm doing all this walking. And yes, walking is really good. It's beneficial for that endurance aspect, but it's not going to target the strength and resistance aspect that is so important for the functional activities like sit to stand and movement up and down the stairs for him, and balance, safety. So you guys mentioned a couple of the suggestions I had: sit to stand, step ups. If he does have trouble with his knees, starting from a higher height or doing a smaller step. Also, sometimes I think that we don't always add in the arms for these activities. So how could you add a functional activity with the arms, with Maybe we'll go to the stairs. What would you do on stairs that would include the arms? Do you have any thoughts? And somebody also mentioned Tai Chi. Yeah, that's really good for balance and strength and control. Okay, somebody mentioned weights and bicep curls. So I would encourage you to think of how that could be functional. So what do we use our arms for? Yep, holding the railing. Yep, on one side, and then sometimes, yeah, lifting soup cans or other items. Yes, carrying groceries. Exactly. I wanted to get to that functional aspect. So yes, and sometimes we talk about holding a weight and just doing repetitions, but how can we kind of get that more related to what we do every day? So carrying groceries, so holding something in one hand, and even just starting with walking with that is going to strengthen your opposite hip. Lifting things from the ground and training the older individual how to do that safely. With soup cans, adding in the component of lifting them up to the cupboard so it actually means something to that person. Yes, you mentioned the cupboard. Great. So upper cupboards, lower cupboards. I also think about carrying laundry baskets, right? So I wouldn't really I like to be sure that a patient is safe to do this because it changes their vision in front of them, but maybe they carry it to the side and work on walking. Or, yes, grabbing things out of the washing machine. So some of that repetition of squatting down and reaching in. Armrest push-ups, yes, are good. Sometimes that's good for triceps if they need those arms to help them stand, but also getting them away from using the hands so much. I also think about push-ups kind of forward because on a table, because this can be helpful for a functional task of even if they need to reach down into a cupboard, supporting themselves, or if they are safe to practice up and down from the floor, that's another consideration that can be a very functional strength activity. But that one I only recommend with supervision. Great ideas. And then don't forget that power aspect. So how you can add that in safely. So if we are doing sit to stand, giving them support so they don't worry about their balance, but then getting them to use those quick type 2 muscle fibers. And it always goes back to who's actually doing this. Only 16% age 65 to 74 actually engaging in aerobic and muscular strengthening. And once you get above age 75, it gets to be almost half of that, 8.7%. So what are the barriers? I am sure that some of these could be included even in younger ages, right? But it becomes even more apparent with older adults. So where that activity is located, having difficulties getting there, thinking about their space that they live in, the functional, environmental, and social factors. Maybe they don't want to be in a place that other people see them doing activity and see them that they have difficulty with that. So that can be a factor as well. Safety, fear, health concerns. They might be worried that it's going to make things worse or cause more pain or fatigue. And maybe they just don't have that social support, which can be a big barrier as well. And just like any of us, sometimes it's just the motivation factor of readiness. And so we need to understand where everybody's at with that. But what we can use are the motivators. So if we can find what will work for that patient, minimize the barriers, and emphasize these motivators or facilitators, that it can help to increase longevity, improve their health status, help them live independently for longer. Those can be good motivators. So for Robert, what are the barriers for him, and how might you facilitate his behavior change? So you can kind of look here. What are some of his barriers? I think some people mentioned this earlier. Yep, medical conditions. So it could be that the osteoarthritis might limit what he wants to do. Lack of knowledge, maybe just not knowing. He said he doesn't know, he's unsure how to do it safely. The arthritis, somebody else mentioned. Yep. And then that concern, fear, exactly. Concern about hurting himself. So there's many factors that could be at play here that we want to be sure that we address for him. So then any thoughts on how you would start to initiate that behavior change? This is a whole nother topic, by the way, but just to get like one or two other ideas, like what would you do with him? To help either break down those barriers or to improve his motivation. Yes, ease into it. Kind of give him that education. We're going to start slow, providing those expectations so that he can see that he can do it and build that confidence. Start with PT if he'll go, right? Sometimes it's just hard enough to get people there. And knowing that if he has that individualized care, he can be less likely to hurt himself and be more safe with that and get the right type of exercise for him. And sometimes people prefer a group. So maybe he starts with a PT so he can learn some of the best ways to do things, and then to reinforce that social aspect and support, he could find a group in the area. Those are critical. And so identifying who the and where the community groups are in your area is one of the best things we can have to help keep people motivated and have that social support to keep going. Check his heart health. So he has some fatigue, so just being sure there aren't any other cardiovascular impairments that are going on. Yep, that's definitely, we want to be sure the medical aspect of things are being addressed. Yeah, any other thoughts? Have some good ideas there. And then in PT, what I would do is make it have that conversation about barriers with him. And has he ever had a exercise program? Is there something specifically right now that's stopping him that maybe we can find a way to limit that barrier? Or maybe he used to do something and now he can't get there, or there's a transportation and we need to modify how he does it so that he can still be successful. Yep, and knowledge is such an important piece of that. Not just with how to exercise and strength train safely, but also reinforcing those benefits. I really like how you put it in that term, because those benefits can be motivating factors to continue on, and relating it back to his diabetes as well, and how it could improve multi-factors with him. Yep. So lots of good ideas, but I think the main point is we have to take the time to have those conversations and find those small modifiable action steps that the individual you're working with is willing and has the confidence to be able to enact, and then helping them work through that, because it takes 6 months more of consistent practice to develop those habits and get into that maintenance phase. So, all right, I think that's everything.